Okay, so last time we looked at the markings that you can see in the different bones of the skull in the lateral view. Now we're going to see the markings in the posterior view in the bones, of course, with those markings. So, in the posterior view, something that you can easily see is the suture between the right and the left parietal bones, which is the sagittal suture. So it's the suture that connects the parietal bone on the left and the parietal bone on the right. And then we have another suture that you can see that we saw before in the lateral view. So this is a lambdoid. So it's the connection between the occipital bone and the parietals. Now, if you see here between the parietal bones and the occipital bone in this part at the base of the sagittal suture, you see a tiny bone here, and also to the left, you see another tiny bone there. It can be several, it can be more than two, it's just an illustration. But these are what we call the sesamoid bones. So they vary in number, and we don't have a specific name, we just have the generic name of sesamoid. Now, in this middle to lower part of the occipital, we have two lines that runs from left to right, one that is upper, the other one that is lower. So this line is called superior because it's above, nuchal because it's in this area of the skull that is called the nuchal area, and then line. So this is a superior nuchal line, and then below the superior nuchal line we have another line that runs from left to right or right to left. This is the inferior nuchal line. And in between we have this protuberance that is called external occipital protuberance. This is the most pointed projection that we have in the posterior area of our skull. This is the one that I told you the other day. If someone falls and hit directly into a posterior part of the head, they hit that area, it hurts so much. And then you can see as well, just below, in the edge of the occipital bone, the foramen magnum. Magnum means big. And then foramen, if you remember, means hole. So it's the big hole. So in this foramen magnum, we have the exit or the entry, depending on how do you want to see, of the spinal cord into the cranial cavity, or the spinal cord going into the vertebral cavity. And then what else can you see? You can see the squamous suture. So remember, it's a connection between the the parietal and the temporal. So squamous suture. So it's called squamous because the part of the temporal that protrudes like this, like a little convexity, it is called squama, like a scale. And then this little part is the occipitomastoid suture, which connects the occipital bone to the mastoid process. Mastoid process is this thick projection of the temporal bone located behind our ear canal. And this inside has air cells, like spaces filled with air. And sometimes some of these microorganisms that can be infecting the middle ear can go and infect the mastoid process, causing inflammation that we call mastoiditis. And then someone has to have surgery for drainage of this infection and the pus. And then you can see the mandible there, the maxilla here. So all of these are features or markings that you can see in the posterior view of the skull. Inferior view of the skull, well, you will see a lot of holes, a lot of foramina. Why? Because a lot of blood vessels goes from the neck area into the skull. And then, of course, we have this big hole, which is the foramen magnum. This is where the spinal cord comes or passes through. And then this is posterior, this is anterior, this is lateral. So this is the foramen magnum here at the base of the cranial floor. And then this is the external occipital protuberance, inferior nuchal line, superior nuchal line. And then on the sides of the foramen magnum, the occipital bone has the hypoglossal canal. So this hypoglossal canal allows the passage of the hypoglossal nerve to go and innervate our tongue so that we can move our tongue. That's hypoglossal nerve. So it's here on the sides of the foramen magnum. And then anterior and lateral to the foramen magnum, we have the occipital condyles. The occipital condyles allows the formation of an articulation with our first cervical vertebrae, which is called the atlas. So you form the atlanto-occipital joint. The condyles are convex. And then the superior surface of the cervical vertebrae are concave, so they fit perfectly. So it makes like a little cradle. So the convexity of the condyles of the occipital bone fit into the concavity of the lateral masses of the atlas, the first cervical vertebrae. They fit on top of each other like this. And because of this, you can have this movement of the head like this over the atlas. What happens when you do this movement in the head like this? What are you saying?
Yes.
Yes, you're doing this, flexion and extension. So that's the importance of the shape as well, if you see. A concavity fits a convexity, and then you can have this type of motion. So this is here in these occipital condyles. So all of these are then features of the occipital bone. Now, what features can you see in this bone here laterally and medially, which is the temporal? So this is what we call the petrous portion of the temporal bone. And then in this petrous portion, something that you can see just anterior to this occipital bone, it's a jagged foramen. This is called the jugular foramen. We have a vein here on the sides of the neck that is called jugular that runs through this jugular foramen. This one drains the blood from our head. The jugular, the internal jugular vein, it runs here. And then anterior to this jagged foramen, which is the jugular, we have a round foramen that allows the passage of an artery that runs here on the sides of the trachea that is called the carotid. And it's going to be the internal carotid. So the internal carotid passes through this carotid canal. And that artery provides blood supply to our brain. So it's a very important artery. Both of them, they run like the jugular vein and the internal jugular vein and the carotid, the common carotid runs here on the sides of the trachea. Then together with these two, we have a nerve that is called the vagus nerve. So if someone commits suicide by slashing the neck, it will have 3 chances of dying. Well, 6 if they do side by side. Because you can either hit the jugular vein, the internal jugular, which drains a lot of blood from the neck, from the head, and the person will bleed. It can also damage the carotid, which has a lot of blood pressure to provide blood supply to the brain. And if not, it damages the vagus nerve that helps to regulate the heart rate. So this is kind of a susceptible area in our body, the neck area. So then, to the sides, we have the view of this in the temporal bone, the mastoid process here. And then here you can see the squama. And then anterior to this mastoid process, laterally, we have the mandibular fossa. The mandibular fossa is a concavity in the temporal bone that looks like this. If you see it sideways, it's like this. It's a concavity that fits the occipital condyle, which is convex. And then, with your mandible, you can do this. That convexity of the condyle slides over the concavity of the mandibular fossa. forming the temporomandibular joint, TMJ. So this is the freely movable joint that we have in our skull. The rest are sutures. And we said last time that because of this movement, we can open and close our jaw to speak and to eat. Sometimes this one can dislocate, especially if someone has a blow here on the mandible. The condyle falls off place, and then the person ends up with an open jaw. And then they have to put it back. There are some weaknesses in which people have the ligaments that hold this bone together, these two bones together. They might be very elongated or very flexible, and then sometimes some people can have spontaneous dislocations in their jaw. And if this is not corrected with time, I mean, the people will learn to pop up back their jaw into the right place. It's kind of crazy, but it happens. So this is where we can make then the TMJ, the temporal mandibular joint in the mandibular fossa. And then you can see this process, which is the zygomatic process of the temporal bone, which together with the temporal process of the zygomatic, which is this, form the zygomatic arch, which is basically this bridge of bone that we have here in the cheek. And now, this bone that you see here at the base of the cranium is the keystone bone in the skull. This is the sphenoid. Every single bone in our skull connects to the sphenoid. And then in the sphenoid, in the mid part, you can see this area, which is the body, and just below to the body of the sphenoid, we have the connection of the bone that forms the inferior part of our nasal septum, which is the vomer. Now, inside the body, we have a sinus, which is the sphenoidal sinus. And then, to the sides of the body, we have these two masses that goes vertically below the body of the sphenoid that looks like if we were legs of a bat. So these will be the pterygoid processes. These will be the medial pterygoid processes, and then in here we have the lateral pterygoid processes. And then on the greater wings, that looks like this if you see it frontally of the sphenoid, you have the greater wings that extends horizontally. In these greater wings is where you have a lot of foramina, which if you start from anterior to posterior, you have ROS. I'm making you kind of neurologist in this case, right? ROS, all are foramen, so foramen, foramen, foramen. So foramen rotundum from anterior to posterior. Rotundum. Foramen ovale and foramen spinosum. All that it means is that this foramen, this hole, it's a little bit round. This one is oval, and this one is jagged. ROS, rotundum ovale spinosum, from anterior to posterior, here in the greater wing. So rotundum is not labeled in here, but it's a little bit anterior here. Then we have the ovale here, and then this is the spinosum.
They follow each other?
No, they're separate. And then anterior to the vomer and anterior to this sphenoid body, we have the openings for the posterior nasal cavity, which is called the choanas. And then in here, we have the inferior nasal conchae in the nasal cavity. And then this bone here, this is the oral cavity. This is where we have our mouth. So this bone in here is the palatine. Palatine has this horizontal plate that forms the posterior part of the hard palate. And these maxillary processes, this maxilla has the palatine processes that together with this palatine bone form the hard palate. And then here we have a line that connects the left and the right parts of these palatine processes, which is called the intermaxillary suture. And then anterior to this intermaxillary suture, just posterior to our front white teeth, which are the central incisors, we have the incisive fossa. And then there are some tiny foramina here in the palatine, but like the greater and the lesser palatine foramina. And then all of these provide nerves, passages and blood vessel passages to provide oxygen and nutrients to the hard palate. Any questions of this inferior view of the skull? So in the medial view, what you can see is the floor or the base of the cranial cavity with whatever we saw before, the fossa. So this is the anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. And here we have the temporal bone with this meatus, which is the internal acoustic meatus. So this is where we have the exiting of a nerve that is called the cranial nerve number 8, vestibulocochlear, the one that helps us to hear and also to maintain balance. And then something that you can see is the sinuses, like this is the frontal sinus in the frontal bone. And then here we have the ethmoid with these little holes, which are the ethmoidal cells. And then the sphenoid, which will be here in the body, has this sinus, which is this sphenoidal sinus. And then in here we have the mastoid process with these mastoid cells that holds air, just like as the other sinuses. And then here is the bony nasal septum. This is the ethmoid, the perpendicular plate, and this is the vomer. This is the hard palate, so this is the palatine process of the maxilla, and the maxillary process of the palatine. Alveolar processes of the maxilla, alveolar processes of the mandible holding the teeth, and then here we have the submandibular fossa. It's not labeled, but that's where we keep the submandibular gland, the one that helps us to produce saliva the most. It's the second largest, but it's the most productive in terms of producing saliva. And then here we have some little tubercles that help to hold a muscle, the mylohyoid muscle. And then this is called the mylohyoid line. And then here's the angle of the mandible. This is the mandibular symphysis, and this is the mandibular body. Questions? This is the pterygoid process of the sphenoid. The internal view of the skull, looking from top superiorly. You can see again the fossas. This is the anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Foramen magnum, here part of the occipital bone. Here are the hypoglossal canals. Then here is the jugular foramen, part of the temporal. Here is the internal acoustic meatus. Now, this foramen lacera, which is on the sides of this part of the sphenoid, which is called the sella turcica, typically it's open in a person under the age of 40. When the person ages, this one becomes calcified and obstructed. The foramen lacerum is not there anymore. Now, this is made by different bones, including the sphenoid, the temporal, and part of the occipital. Then this is the medial part of the sphenoid, so this is the sella turcica. The sella turcica is where the hypophyseal gland fits into. So the sella turcica has the hypophyseal fossa. And maybe this is an E. Hypophyseal fossa. To hold the hypophyseal gland.
That's the pituitary gland, right?
Mm-hmm.
So, Professor, will it still hold it, even though after the age of 40, that saddle-looking thing is gone?
No. We're talking about two different things. The foramen lacerum, it's a hole that get obstructed.
Okay.
But that's different. Like the hypophyseal fossa, if you see it sideways, it will look like this. So this is a side view, and here we have a tiny gland, that is the pituitary gland. This is like the size of a pea. It's very tiny. And sometimes this one enlarges, and it's going to compress cranial nerve number 2 that runs in here, which is the optic nerve. The optic nerve crosses, the one from the left crosses to the right part of it, and the one from the right crosses to the left. So if this one enlarges, compresses this optic nerve, so sometimes they can be a little tumor, and then it compresses optic nerve. Do you remember cranial nerve number 2, optic nerve, what it's good for? Allow us to do what? To see, right? So if you compress the nerve that allows us to see, would you be able to see well? No, you will have vision problems. So we're talking about this little region. And then, if you go back to here, so we have here this sella turcica here, and we have this tiny gland, the hypophysis here. If someone has a tumor, it's going to have vomiting, nausea, and then headaches. It's not going to be fun. So if you were a neurosurgeon and you want to remove that tumor from the hypophysis, the pituitary gland, which is found in here, would you access to this gland going through these bones or going through the nose? What is easier? It's easier. It's not only easier, but it's less dangerous. Imagine someone trying to remove a tumor from you, from this area, and going through this bone And then they have to go through these lobes of the brain, like the frontal, parietal, temporal. Don't you think it's going to be a lot of damage? What do we have in the nose, in the nasal cavity? What do we have? Just air. Yes, just a space. So they go through here, they break this little wall here of the sphenoidal sinus, and they break this little wall in here, and that's it. And they enter and they see that tumor and they remove it. This is called transsphenoidal surgery because you go through the sphenoid. That tiny gland that looks like a pea can enlarge, can cause trouble, and then it has easy access to the nose. That's not in the book, guys. So, then anterior to this sella turcica, we have the optic canal that allows the passage of cranial nerve number 2, optic nerve, the one that allows us to see. I wrote down that before in the board. And then anterior to this, we have the ethmoid. This bone has this little projection that is called crista galli or Cook's comb.
Do you spell it? Please?
Rooster. Roosters. Yeah. So in that part, we have a membrane that protects our brain that's called dura mater. It is inserted into that area. And then on the sides here of the Cook's comb, the crista galli, you have the plate of the ethmoid that is called the cribriform plate, through which you have the passage of cranial nerve number 1. So the ethmoid looks like this. It has a horizontal plate, and we're looking at the anterior view. And this is the ethmoid. So it has a horizontal plate and a perpendicular plate. So this one, the one that runs like this, it makes our nasal septum, the bony nasal septum, the upper part, and the horizontal, it forms like a seal, but it's not completely sealed. It has little holes here. The horizontal plate has holes. So that's why this one is called the cribriform plate. Crib means sieve. Sieve has holes. So then through this plate you have olfactory nerves. Olfactory nerve axons running through there. Olfactory nerve is cranial nerve number 1. Cranial nerve, you abbreviated CN. Olfaction is smelling. So in the roof of our nasal cavity, the axons runs through there and goes and connects into the brain. So that's why we have a bunch of holes here. And then here we have foramen rotundum, this one, the round one, and then ovale, and then spinosum. Questions? So that's the internal view of the school. Now let's look at how the orbit, nasal cavity, and paranasal sinuses are structured. So our orbit is made by 7 bones, very tiny, most of them. We have frontal, one part of the frontal, one part of the maxillary, one part of the zygomatic. So these are kind of large bones, facial bones, and then we have the sphenoid, which it forms like the posterior wall of the orbit, and then the ethmoid, which is found in the middle side together with the lacrimal bone, and then inferior and medial is the palatine. And the function of the orbit, it is to protect the eye and anchor the eye muscles so that we can move our eyes in the directions that we need to move them. Now, the nasal cavity is made also by different bones. The ethmoid above the nasal septum, the bony nasal septum, the vomer below the nasal septum, nasal bones externally, the palatine bone inferiorly, and the sphenoid and the maxillary bones. So it's 1, 2, 3, 4, 5, 6 bones that form the nasal cavity. And the function is, of course, to support the nose, to provide the structures, the structure of our nose, and also to allow us to inhale air. And then surrounding this nasal cavity, we have the paranasal sinuses that drains into the superior and inferior nasal meatuses, which are below the superior and middle nasal concha. Functions of the paranasal sinuses is to produce mucus, filter and humidify the air, warm the air, and to lighten the school, and to help us to give resonance to our voice. The largest will be the maxillary sinuses that we have in the maxilla. Second largest, frontal. Third largest will be sphenoidal, and the ethmoidal cells are very tiny, so those are the smallest. So here is the frontal view of these sinuses. Here will be the frontal, ethmoidal, maxillary, and the sphenoidal will be somewhere in here. And then we have several cavities besides these sinuses. We have the orbital cavity, the nasal, of course, oral cavity, and the cranial cavity. Lateral view of the nasal cavity. We have these projections, bony projections. This is the superior nasal concha, which is part of the maxilla. We have the middle nasal concha, which is also both of them are part of the ethmoid, not the maxilla. So superior nasal concha and middle nasal concha are part of the ethmoid, and inferior to this, it's its own bone, the inferior nasal concha. And then we have spaces in between, the superior, middle, and inferior nasal meatuses. Then here you can see the sphenoid bone, an open view. Here's the sella turcica, where we have this gland, the pituitary gland. And then here we have the hard palate, bathed by the maxilla and the palatine. And then here is the conches, as seen in the frontal view of the nasal cavity, superior, middle, and inferior. They help to increase the speed of the air as it's going from the floor of the nasal cavity into the narrow space here in the olfactory area in the roof of the nasal cavity. Questions? So this is a shadow view of the sinuses, maxillary, sphenoidal, frontal, and the ethmoidal cells. Something about the maxillary sinuses is that they are close to the second molar, superior molar. And then if someone has infection of the second superior molar, that infection goes into the root, that infection can mimic sinusitis because you will have nerves that will be irritated, there you will have inflammation, and then it will mimic sinusitis, signs and symptoms. Now, if that infection gets complicated, that can basically break the floor of the sinus, and then the person will have pus going from the teeth into the maxillary sinus. And the floor of the maxillary sinus is very thin, so it's easily breakable. Questions? Okay, so details about the fetal skull. Well, since you have unfused sometimes bones, like the frontal, they can be unfused. You can have more bones than the adult. And it's only until these get fused with time when you have the number of bones that you have in the adult. So now in the fetal skull, as we discussed before, we have soft spots like the membranes where the skull bones are going to form eventually by calcification, intramembranous ossification. So as the baby borns, then these soft spots will be replaced by solid bone, but then they have different locations, these soft spots, they have different size, and then they have different closure time. So here we have the anterior fontanelle, which is located between the frontal bones and then the parietal bones. So this is the largest fontanelle, closest between 18 months to 24 months. This is the last one to close. And then we have this posterior fontanelle. This is between the parietals and the occipital. And this is smaller than this anterior one, and it closes by 2 months of age. And then laterally, we have the anterior lateral or sphenoidal fontanelles. This is located between the frontal, the sphenoid, parietal, and temporal. This one closes at 3 months. So this one first, and then this. And then the mastoid, this one. This one is located between the temporal, parietal, and occipital, and closes between 6 to 18 months, just as this anterior fontanelle. What is the function, if you remember? Or functions, it has more than one. What are the functions of the soft spots?
It helps
During birth, allows the baby's head to pass through the birth canal if it borns through the birth canal, right? But what else? What is important during the first 2 years of a child?
That's the growth of the brain, right?
Yes, the growth of the brain. The physical growth of the brain is at its maximum. So you need to have place for expansion. Okay, now let's look at the vertebral column. So the vertebral column or spine, it is located in the axial skeleton. It is made of different vertebrae that are named according to the region where they are located. So we have 33 vertebrae, and they are numbered according to the region where they are located, and they are named as well from the region where they are located. So we have 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 3 to 5 fused coccygeal. Functions will be to support the head, the trunk, protect the spinal cord, and provide attachment for the ribs and as well for muscles to keep our posture. So 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, 3 to 5 fused coccygeal. Within the spine, we have normal curvatures, 2 that we're born with, 2 that we develop after we're born. The ones that we're born with are called primary, the ones that we develop are secondary. So, the cervical and lumbar, if you look sideways, they are concave. So, cervical and lumbar are concave. These ones are the secondary, the ones that we develop after we're born. And then thoracic and sacral are convex. So, convex, convex. These ones we're born with, these are primary. Well, why we have these convexities in the thoracic and in the sacral area? Why we born with this? Well, because the space in the uterus is limited. So you have to fold like this. So we have convexity, convexity. And then when you're born, you start exploring the world. What is the first thing that a baby does to explore the world? Before that. Before rolling over. Huh? Lifting your head. So, as the baby lifts the head, it forms this concavity, which is the cervical curvature. And then at 18 months, before that. It's like at 12 months or so, right? The baby starts walking. So that's when it develops the lumbar, which is the one that it is concave as well. So cervical first and then lumbar after you're born. That's how they are formed. So now between the vertebrae, we have disc of fibrocartilage that we call intervertebral disc that helps to cushion the movement between the body of the vertebrae and helps to absorb shock. So this will help for flexibility for vertebral column, and sometimes a disc can herniate, so that means that it breaks a piece and allows the soft part of this disc to exit to one side and compress a nerve, and then the person ends up with pain and numbness. So here is the lateral and anterior or front view of the vertebral column. So if we subdivide it by regions, this will be cervical, thoracic, lumbar, sacral, and coccygeal. 1 through 7, C1 through C7 will be the cervical vertebrae. T1 through T12 will be the thoracic vertebrae. L1 through L5 will be the lumbar. S1 through S5 will be the sacral. And CO1 will be the coccyx. This is the cervical curvature, lumbar curvature, thoracic curvature, sacral curvature. Now, sometimes some people can born with defects in the vertebrae or in the spine, and then they can have lateral rotation of the bodies of the vertebrae. This is called rotoscoliosis. Sometimes some people can have exaggerated lumbar curvature. This is called lordosis. And then sometimes some people can have exaggerated thoracic curvature, and this is called kyphosis. So kyphosis affects thoracic area. Is hunchback. Lordosis is for the lumbar area. Person will be like this. And then rotoscoliosis, the person can be like this to the side. Physiologically, a pregnant woman can have lordosis. Why is it called lordosis? Well, lords, they used to, in England, they used to wear heavy capes. They had in their neck. In order to walk, they have to do something like this. Okay, so markings of the typical vertebrae. So you have a body. This is the superior view, top view. So this is the body is anterior. You have three processes, one that goes to the back. This is the spinous process, the one that we can feel in the middle of our spine. This is the spinous process. And then two on the sides that are called the transverse process. In between the spinous and the transverse process, we have this little gap that helps for the muscles that help us to maintain a posture to connect there. And then in between these processes and the body, we have this space that is called the vertebral foramen. This is where we have the spine, the spinal cord. And there is an arch that forms between the spinous processes, the transverse process, and this part that is called the pedicle, that is close to the body. And then the lamina will be the bony connection between the spinous process and the transverse process. Now, since this is the superior view, you can see this facet for articulation for the next vertebrae, the adjacent vertebrae, superior vertebrae. This is the facet of the superior articular process, which, if you see it in the angle view, this is the facet of the superior articular process that articulates with the facet of the inferior articular process, which is this. So you can connect this top vertebrae to this lower vertebrae so that you can do this type of movement, flexion, extension of your trunk. So by this articulation. And then in between these two vertebrae, you have a foramen that allows the exit of these spinal nerves. This is the intervertebral foramen. And then between the vertebrae body, you have this disc. This is the intervertebral disc. Any questions about these views of the vertebrae? So the body of this vertebrae is the one that carries the weight of our body itself. Now for the intervertebral disc, well, it has another part that is called the annulus fibrosus. This annulus fibrosus is made out of collagen fibers, strong collagen fibers that holds this soft part of the intervertebral disc that is called the nucleus pulposus. As we age, this becomes dehydrated, this part, and then that leads to be less flexible. So these collagen fibers can break really easily, and then you have the exit of the nucleus pulposus through this weak point that we have here, and that will compress a nerve. Typically that affects areas of high mobility like the cervical area or the lumbar area, rarely in the thoracic area. So if you compare the vertebrae in the different regions, you can see that the cervical has a small body. It has a triangular shape vertebral foramen. It has transverse process with holes. These are the transverse process with holes. This is called the vertebral foramina, the transverse foramina. Has a short spinous process, short transverse process. This spinous process typically is split, so this is called bifid spinous process. And because this one is the one that holds less weight than the rest of the vertebrae in our body, these ones are the smallest type of vertebrae because it only holds the weight of our head. As you move down the spinal column, the vertebrae become bigger and stronger because they have to carry more weight. So out of the three types of vertebrae, cervical, thoracic, and lumbar, which one will be the strongest? The lumbar, because it carries the weight from here up. The second strongest will be thoracic, because we'll carry the weight from here up. And then the cervical will be the less stronger because it only carries the weight from here up. For the thoracic, it has medium-sized body. It has a round vertebral foramen, has long transverse processes to articulate with the ribs. So it has these facets, which are the costal facets. We have transverse costal facet, and also we have it here in the body. So that you have the ribs, the transverse tubercle of the rib articulating here, and the head of the rib in here. It's only in the thoracic area where we have ribs. We don't have it in here, we don't have it in the neck. And then the spinous process is long and points inferiorly in an angle. For the lumbar vertebrae, it has the largest body, which is kidney shaped. It has a flat vertebral foramen, short transverse process, and the short, thick spinous process that ends in a blunt ending. And this one has this massive body, very thick, to hold all the weight. So any questions? For cervical vertebrae, for the two first cervical vertebrae, they have special names. The first one is called atlas. It's the only vertebrae that doesn't have a body. The rest have a body. Instead of a body, the atlas, which is this, has lateral masses. So these are the lateral masses. And then it has two arches, the anterior, which is shorter, than the posterior, which is longer. And In the anterior arch, you have an anterior tubercle, and in the posterior arch, you have a posterior tubercle. And then just as any other cervical vertebrae, it has this transverse foramen through which vertebral arteries and vertebral veins runs into to provide blood supply or drain the blood supply from the posterior part of our brain. And then in the typical cervical vertebrae, the spinous process usually is bifid or split. Now, in this anterior arch, this atlas has a surface for articulation with this process from the second cervical vertebrae. The second cervical vertebrae is known as axis, and this process that faces superiorly is called the dens or odontoid process. So this is the facet for the dens. So the dens, if you look laterally or superiorly, you will see that the dens fits anteriorly to this is like, let's say this is the atlas, this is the axis. It fits anteriorly like this, and then you can rotate the axis over the atlas so that you can knot. So this forms the atlantoaxial joint. So we have a transverse ligament that holds the dens over this. And then this one has a body, and it has the rest of the parts as the other typical cervical vertebrae. So we will continue with thoracic and the rest of the vertebrae.